Morning, you guys. I thought I would come and chat to you about my migraine and my recent neurology appointment because I feel like it was really positive. So it was a week ago today, actually. And remember I said did I tell you I was struggling to find somebody to look after Watson? And I finally sent him with his walker after his walk, and that all worked out perfectly. So yeah, I went for my appointment. I had to wait an hour to see the neurologist, which I actually didn't mind. I mean, it wasn't nice waiting for an hour, but I don't mind because I'm sure he's only supposed to see us for 10 minutes and it always spends half an hour with each patient. So I appreciate that. And if that means that I have to wait longer to see him, I'm absolutely fine with that. And remember as well, he told me he was in a position whereby I had exhausted all of the migraine treatments except for this list of medication, which he could just send to the GP. But he said, I'd like to still see you and follow up, just because he thought I was a complicated case for the GPs. And I really appreciate that. So I went in knowing that there wasn't going to be any big treatment options. There wasn't going to be anything new. You know, he's told me all of the new things coming out are basically like CGRPs. You know, there's nothing that I haven't already tried, and that there's this list of medication. And the last time I saw him, we'd agreed I would start on venlafaxine. That was the next one on the list of medications he'd offered. And so that's all he knows, that, you know, the last time he saw me, which like I said was a year and a couple of months ago, I was going to start on venlafaxine. Now, the first thing that really kind of cheered me up, if you like, is the Tramadol confusion. Now, I can't remember if I told you guys this. I'm sure I did, because it's been on my mind ever since, and I've done quite a few videos since seeing him. But he had written a letter to my GP and it said, if venlafaxine works, she should stop Tramadol. And that really just put the fear in me, because I can't take, I can take, triptans, but they don't work for me. They don't work for my migraine. And so the rescue medication that I have is Tramadol. And this is why I'm allowed Tramadol. It was very rare that Tramadol would be given to people with migraine, but it is a rescue medication for me. It works. It even works on my dizziness, which is very strange because it can cause some people to be dizzy. But he's always made it very clear that he's kind of anti-Tramadol, if you like, or he's anti-opioids. And so I just thought, that's him saying, you know, it seemed sometimes like his goal might have been to get me off of Tramadol rather than to put me in a better position with my migraines, even though he's a very, very lovely guy, you know, and always seems to be very empathetic. You know, I mean, the minute you see him, he asks if you've got a headache now. He asks if you want him to put the lights off. He closes the window for me because he knows that it's noise for me. So he's lovely. But I just was thinking that I knew there's no cure for migraine, and that no medication, or it's unlikely that any medication is going to be that I start taking it and suddenly I have a cure. This is what I think my family and friends think and hope for. Of course, I would love that. But I know that the reality is that actually seeing the neurologist, his goal is to get me a 30% reduction in the severity and number of migraines that I have. So it's not very much when you're having migraines every day. You know, it means that you'll still have migraines 3 or 4 days a week. So in my head, if the venlafaxine worked and gave me a couple of migraine-free days a week, but I wasn't allowed to take Tramadol, then I would be in no better situation than I was before, and maybe even worse, because I was in a situation where I had migraines every day, but I could take Tramadol on 3 days a week, which would give me 3 days relief, if you like. And so that's what was really worrying me. Anyway, so I said that to him, and I said, you know, I'm just really worried. What am I going to use for rescue medication if nothing ever gives me, unless something gives me 5 days a week or 7 days a week relief, you know, what am I going to do? Anyway, it was a miscommunication. It was a misunderstanding on my part. What he was saying that for is because, and I remembered as soon as he said it, I remembered that he told me about serotonin syndrome. And I mentioned it to you guys. I knew that going on to venlafaxine, I would need to be aware that there was a risk of getting serotonin syndrome, which is an event that can be extremely serious and life-threatening. That comes from taking too many drugs that affect the serotonin. And I'm already on amitriptyline. I think amitriptyline is one. Tramadol is one. And venlafaxine is one. And so with the venlafaxine and Tramadol, if venlafaxine was working effectively, Tramadol would be removed. It would be the drug that was removed, because taking the two of them together, there would be this ongoing risk of serotonin syndrome. And that's what I didn't realise. I didn't realise that if the venlafaxine worked, I would have had to stop the Tramadol. I didn't know that. But as soon as he said it, it made sense. He was talking about the reaction between the drugs. So being on gabapentin, there's no worries at all. I can stay on Tramadol. There's more worries about like, I guess, respiratory depression and things like that. But I have, monitored that and gone up very, very slowly because I'm on a high dose at the moment. And, I'm very aware of not taking any, I'm aware of Tramadol, codeine, amitriptyline, all of that. And to be careful that I'm not taking too much, if that makes sense. So that was a relief. That was relief and kind of good point number one. The next thing was where to go forward in future, or how to go forward in future. And so I told him, the venlafaxine did not work for me. I've been taking gabapentin, and he was so lovely. Do you know what he said to me? Because he said, firstly, I never see anybody wait out gabapentin as long as you did. He said, and that is really good. But I kind of had experience with amitriptyline where I was lucky enough that I didn't work at the time. It was the period of 2 months where I had left one job and was applying for other jobs, the NHS actually, and I went back to the NHS a couple of months later, and I was able to take amitriptyline and just sleep most of the time to get through the side effects. So I understand why most people can't, persevere. But with amitriptyline, I've been on it 20 years now, I think. A long time, and it's an amazing drug for me. What it does for my bladder is just amazing, and sleep. And so I knew that persevering was good. My dad had tried most of the drugs I've tried, and with amitriptyline, he just couldn't bear it, And so I knew that it would be worthwhile. But on top of that, I had seen a physiotherapist who's also lovely. He's at my GP practice. I'd seen him he gave me steroid injection in my shoulder a couple of times, and he also saw me about the nerve damage in my feet. And he was saying, I was talking to him about gabapentin, and he was saying, please persevere with it. He said, because I've seen so many people get relief from gabapentin if they can just bear with getting over the side effects. Same goes for pregabalin, because it's the same kind of thing. I was telling him that I had persevered with the gabapentin, and I was also telling him about the pain reprocessing therapy that I was doing and whatnot. And he said to me, I hope this doesn't sound condescending, but I'm really impressed with you. And I was like, oh my goodness. I was just like, I can't believe he's saying that. I was all kind of awkward, and I was like, no. And he went, no. He said, see this improvement that you've had. He said, this is all you. And he said, and I'm really, really impressed. And, I keep all my spreadsheets and my migraine diary. And he said, this is really useful information for me. And that means that I can help you. And so that was lovely for him to say. I really appreciated that, So with the gabapentin, you guys know I've come and said to you, I thought the gabapentin was working. Then I didn't think it was working. Then I've come back and said, nothing's working, but I'm still taking the gabapentin. But actually, the gabapentin is working. Is it a cure-all? No. Is it a miracle cure? No. But it is working. And Kev put it in such a way that I was like, that's exactly it. Although I'm now realising I said it to the neurologist, and I thought he's going to be thinking, what? You're sitting here in my office. But hopefully he understood what I mean, and hopefully you guys do as well. But Kev said it's taken you from bed-bound or sofa-bound to house-bound. And I was like, that's exactly what it's done. So gabapentin has meant that on my non-Tramadol days, I am no longer just lying on the couch for the whole day or in bed. Always used to have to go to bed at some point and sleep for a couple of hours. And then the rest of the time I was on the couch or trying to do things. And I'd be really pleased if I managed to, get myself to have a shower, or if I managed to get Watson's game ready, or managed to take Watson across the road for a pee and back again, But those were non-Tramadol days. On Tramadol days, I could do a lot more, So that's discounting that, because obviously the goal would be to not need that level of pain relief. But it's taken me to a point where now on non-Tramadol days, I actually can't remember the last time I had to sleep. That's not true. I did at the weekend. I lay down for an hour, but it's now rare, within the last couple of weeks, that's the only time I've had to lay down. And I now make the dinner every day, which is wonderful for me, because it means we can eat earlier, and Kev's home earlier now as well, so he could do it in his new job. He's not commuting so far. I can do the housework now. I can take Watson on a little walk. I wouldn't necessarily want to drive, and I can't always take him on a walk. I can't really do the training with him unless I've taken Tramadol, because that's really, my head is just too kind of foggy for that. But I can do housework, and like I said, I can kind of potter around the house, and I just love that. But housebound is because I often feel too dizzy and too unfocused to drive, and so I wouldn't really be able to drive, and I wouldn't be able to work again. That would kind of be my goal. But it's working in the sense that the NHS, like I said, their goal is not to get you back to work, unfortunately. It's to get you out of severe pain. And like I said, in my case, to reduce, or in the case of migraines, to reduce the severity and amount by 30%. So yeah, gabapentin is working. So the neurologist said that he thinks it's worth me trying the maximum level. I was currently on 800 milligrams 3 times a day. It's a very high dose. And he said to take 900 milligrams 3 times a day, which is what that's the maximum the GP had said they were happy to give me, because that's the amount you can go up to for nerve pain. And that's, in their head, I think they were like, that's the kind of primary reason you're on it. Although for me, the primary reason was migraines. So 900 milligrams is what I started on today, and we'll see how that goes. But my neurologist said he's going to write to the GP and confirm that he would support me going up to 1200 milligrams 3 times a day. I mean, I don't want to be on that amount of tablets, because it's going to be 4 tablets 3 times a day. So 12 tablets a day just for the gabapentin. And I've got many other tablets to take, and I can't take them with water. So I take them with raw carrots, but still it's eating a lot, But that's still hope. And I think, well, that's been quite slow, the recovery from bedbound to housebound, but that's still quite it's big for me. I'm really happy with that. I mean, like I said, I can't go back to work. I couldn't sit at the computer. But I can sit at my iPad. I can sit with my iPad here. I can film. I'm on Tramadol today, but I can film a lot of the time. I couldn't edit, but there's a lot more I can do. So I'm happy with trying up to 1200 milligrams 3 times a day. I'm a bit scared, but I'm happy that there's that option. What he did say was there is a risk at that level of getting Parkinsonian syndrome. So I already knew this, but I had forgotten about it. But he said it would be like as if you had Parkinson's. So maybe the hand tremor, maybe the head tremor, maybe the movement where I couldn't walk properly. And I'm very aware of those, because obviously we're looking after Kev's dad at the moment, and he has Parkinson's, and my nan died of Parkinson's. So I have seen all of that, and would recognise that, I think. So if that happens, it's only temporary. It's not Parkinson's. It's just Parkinsonian syndrome, and I would need to immediately reduce down to the level I was on before that started, and not even just stop the drug, But what he did say is that 800 milligrams is quite a high dose. He said, so I feel like you would have got that already if you were one of the ones that would get it, if that makes any sense. So he's hopeful that I won't get that. But yeah, that's a big downside. That's really all there is that he can offer, which like I said, I already know that. And he was saying that with other types of pain, the last resort is sending people to the pain clinic, but with migraine, they won't accept people in the pain clinic. I didn't know this, actually. And I'm not sure why. And he's kind of frustrated that they won't. But he said it's just, I suppose they've had poor results from CBT with migraine before. But he's delighted that I'm doing this pain reprocessing therapy, But the other thing that I talked to him about was, and I'm sure I've mentioned this to you, the greater occipital nerve block that you can have in your occipital nerve. And I was saying to him that in Glasgow, they do this occipital nerve block and blah, blah, blah. And he got very animated when I mentioned that. And he said, oh, yeah, it's really good. And he said, unfortunately, in our area, they won't do it. So I go to the hospital in Edinburgh, and said, they won't do it because the results and the cost, etc., did not work out. But I know that data can be changed, to represent certain things. And also, what am I trying to say? It just depends on how you report the data as to what you see. And it's not always done purposely, but sometimes it is. I know when I was in research, we had to submit some figures to the government. And my then boss, who's a cardiologist, asked me to do the figures twice. And he said, I want you to do one doing it using median, and the other one using the mean, the average. So the average in both cases, but median and mean. And whichever one is the best, he said, that's the ones we're going to submit. Now, that's not illegal or anything, but it is just, and it's not fudging the figures, but it's just changing the way you look at them. And so it's still an average, but, you know, if the median was better, which is like writing the figures out and just choosing halfway rather than adding them all together and dividing them by the number. And so I think that's what happened with this occipital nerve block. And so it's not allowed here. You know, he said because it was maybe tried in everybody with headache and it didn't work that well. It worked best for people with cluster headache. And he said he feels that it would be a great option for me because people with refractory migraine that haven't responded to traditional treatments where everybody else is responding have the most chance of responding to this occipital nerve block. And he was saying there's another one that's like a multi-nerve block that goes all the way up the head and does the forehead and blah, 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 you know. And then he kind of looked a bit crestfallen and he said, but unfortunately, I can't refer you to Glasgow. And I was like, oh, no. I said, what I was asking for that for was because I would go privately. And I said, but my understanding is going privately would knock me off of the NHS. And so I just wanted to see you first and tell you that that's what I'm considering. And he sort of smiled and he said, oh, okay. He said, I think that would be a brilliant option for you. And he said, it's also diagnostic. He said, because kind of the same as I was told with the gabapentin, that if the gabapentin works for me, it's likely to be a nerve that's causing all of my problems, a nerve problem. And he said, if that occipital nerve block worked, then my headaches are coming from my occipital nerve, and that's kind of the core problem, which would be really useful, you know. But he smiled and he said, I will 100% still be your neurologist if you have this treatment. And I thought it was just so sweet the way he said it, you know. And I was like, oh, really? So I can just go and have it now? Like also with taking the gabapentin? And he's like, absolutely. He said, because it's a treatment that, unlike drugs where, you know, you might have to wait months to see if it works and then the effect will continue because you continue to take the drugs. He said that treatment should really work or not work almost immediately. It can take up to a week or so to work in some people. And he said the problem is it may only last a couple of weeks or the effects may last a few months. You don't know. I have hope that it would last longer because I have the steroid injection in my shoulder and it lasts me a long time. I was looking at when I last had it, and because you could have it, I think you can have 2 a year, maybe every 6 months. Yeah, so my last steroid injection and nerve test was on the 8th of May last year. And so nearly a year, you know, it's only a couple of months away till May. And it's only in the last, well, so I suppose it's probably 6 months it lasted. It's only the last couple of months that my shoulder started hurting again. And I've had that twice and it really lasts well. What was my point? Oh yeah, the occipital nerve. So my hope would be that it would last longer in me. Anyway, so I could not have been more delighted. I was so excited because I was like, there's nothing stopping me now. I can go and get this greater occipital nerve block done and see if that helps. And then even if it doesn't help, it gives me information that it's not coming from the greater occipital nerve. It's coming probably more from, I don't know, the vagus nerve or whatever, you know. But if it does work, okay, it's going to be really difficult because it depends how long it lasts and it's expensive. It's like it's going to cost £600 and you'd have to keep having it done. But to have something that would give you relief, especially if it was continued relief for a couple of weeks, would be amazing. So that was pretty much everything from him. I just want to briefly touch on the fact that a lot of you give me recommendations and I truly appreciate them. And I think, or I wonder if they're thinking, why doesn't she talk about that? Or why hasn't she tried that? I always note down what you guys have suggested and I always look into it. And it may be that I've tried it before. Hopefully I've responded to you telling you this. Or it may be that I just haven't had the chance to discuss it with the neurologist or the GP because, you know, you've only got a finite amount of time with them and sometimes it's just something that they're not going to give you, like low dose naltrexone, for example. I would have to try and figure that out myself, like maybe see a private GP, I guess, and then find a compound pharmacy. That's also something that I can only take if I stop Tramadol, and so I'm hesitant to do that. There's no point taking it whilst I'm taking gabapentin, if I could even take it with gabapentin, because I want to see the gabapentin through and see if that works. You know, you've got to see each treatment through so that you know what's working. If I take loads of things and do loads of different treatment options, then I'll never know what's working. But I do truly appreciate all suggestions and I note them down and I investigate them and try them. So yeah, that was pretty much it. That was all that was discussed in the half an hour. We went through my figures, my migraine diary figures, and it's definitely, I don't have as many severe migraines, which is why I'm no longer bedbound or sofa bound. They are moderate, meaning that I can get stuff done in the house, and all the rest of the things that I've already told you. They've gone from severe to moderate, and there's more mild days. I'm still not having many. I'm having 2 or 3 days a month where they're really mild, if you like. Anyway, so that's the plan going forward. So I left his office and was very excited to start organising the greater occipital nerve block and to take the higher dose of gabapentin. My one concern with gabapentin is I've started at 100 and increased by 100 up until now, 800, 3 times a day. And I feel like it might work for a little while and then very quickly wear off. So my concern is that it may work at 1200, but that being the limit, it may then just only work for a couple of months, and then I'm kind of scuppered. Then I know the whole process of coming off gabapentin is going to be a nightmare, but we'll cross that bridge when we get to it. But I got onto the National Migraine Centre and filled in my form for referral, because that's where I had seen that you can have a private consultation through the National Migraine Centre, and they do lots of treatments. And I had seen that greater occipital nerve block was available in Glasgow. When you put into Google, greater occipital nerve block, National Migraine Centre comes up in their little summary, and I was like, right, perfect. So I got in touch with them. I got a phone call from them almost immediately, which I was kind of annoyed about, because there was no space to say, please don't call me, because I generally don't do phone calls because my voice speaking in the phone is loud, but also the voice of somebody right in my ear is just, I can't bear it. But they said to me they don't do it in Glasgow. I could not believe it. I was like, what? They don't refer to Glasgow? And it's just another thing on my list of ranting about Google AI. The information is not correct. So when I went and looked into it a bit more, even though it actually, when you put in National Migraine Centre, Greater Occipital Nerve Block, Edinburgh or Glasgow, it comes up and says it's available. It gives you the prices. But it's not. It's not available in Glasgow. It's not available anywhere in Scotland that I can see. Other than I found this one place, but it seems like it's a cosmetic procedure clinic, and it is run by somebody that was a headache nurse for 10 years, but I need to have a little bit more of a look into it. It's in Glasgow, funny enough, and they seem to offer it. Now, I've emailed them and I'm hoping to get an email response, and that'll give me some kind of idea, are they on top of things, and are they professional and quick, and what they respond to as well. But the National Migraine Centre could only refer me to London, and it wasn't even like central London. It was like Finchley was one of the places though. And then they had a place in Weybridge in Surrey, and like it was nowhere that was easy to get to. So I bawled my eyes out, put the phone down and bawled my eyes out. And then when Kev came home, I told him about it, and he was gutted for me, bless him. And he's like, well, that's fine, we'll get you to London. And I was like, he says it so simply, I was like, just get me to London. And I was like, there's the expense of the flights. If I can even get there and back in one day, because I did that once when I was going to IMATS, and my head was nowhere near as bad then, and I really struggled. It was a tough day, and I said even that would mean I'd have to stay overnight somewhere. Then we've got to figure out what to do with Watson, so he's probably going to have to take annual leave because he needs to be here to look after Watson. And I said, and also then if it does work, I don't know if I needed somebody to take me home afterwards. I don't think so, but I was like, then if it does work, I'm not going to go to London every month or so, or however long it lasts, But he was like, that's not something to worry about. Let's get you to London and see if it works. And then we'll take it from there. He's so good with things like that. But I really would like to avoid going to London if at all possible. But I'm going to have a look into it and see how I can get there. And yeah, I know at least with that one, it would be quick. I think I could get a quick appointment. To actually have the treatment, So I'm gutted. I'm really gutted. But today it's on my list to look into this other lady. If my head stays okay enough for me to do some research, then I'm going to have a look into her and her clinic and see what that's all about. Like I said, they mainly do aesthetic work, so Botox and all that kind of thing. which even Kev was like, yeah, he doesn't really want me to go there. He's like, I'd prefer you go to a medical place rather than an aesthetic place. But I think they do that because it's an injection. It's not something that you can mess up, you know. They're not going to give me brain damage or anything. You know, the worst that can happen is she's not a good injector and I get bruised and inflamed. But yeah, I don't see that there's anything, from what I've investigated, I've had a look at that, there's nothing that can go wrong with it, you know. So that's everything to tell you. I've just realised I was going to use this blooming microphone to see if it made it sound better. That's everything. Thank you so much for listening, especially if you're still here, because that was a long video. And I wish you luck with all of your attempts to get better as well, because I know everybody's on this road with me. You know, a lot of you are struggling with chronic pain, not just migraine. A lot of you are struggling with chronic pain. And, you know, thank you so much for everybody's response to my mental health video as well. That was really interesting, actually, to see that, because I could do a lot of videos on mental health and chronic pain and dealing with it, and, you know, how to kind of do housework when you've got chronic pain, because I've got some advances happening with Ehlers-Danlos as well, you know, of course, because I'm aging. And so there's, I think I'm always going to have enough health issues to talk about on here. Anyway, I need to shut up and get on with life. So thank you again so much for watching, and I'll speak to you again soon.